Hi, everyone. We're just taking a minute to get set up. Great. Good morning. Hi, everyone. Thank you for joining us this morning, afternoon, evening. We're thrilled to be here with you for an exciting session by the Community of Practitioners for Accountability and Social Action in Health, otherwise known as COPASAH. Today's webinar will be on innovations and opportunities for social accountability and health over the last year and since the community's global symposium in 2019. So we have a lot of really interesting innovations to cover today. My name is Eve Brecker. I'm the Associate Director for Civic Engagement at PAI, and I will be your MC throughout the session. So to kick us off and get us started, I would like to introduce you to Dr. Aminu Magashi Garba, who is the coordinator and CEO of the African Health and Budget Network, which is based in Abuja. And AHBN serves as the current host of the COPASAH Global Secretariat. Aminu, over to you.
Thank you very much, Eve. Hope you can hear me well. Okay, so distinguished colleagues and friends, practitioners, and associates of COPASAH, it is my sincere pleasure to welcome you to this global webinar convened by COPASAH as we are wrapping up the year 2022. COPASAH is community of practitioners on accountability and social action in health, where practitioners share interest and passion for the field of community monitoring for accountability in health, interact regularly and engage in exchanging experiences and lessons, sharing resources, capacity, and methods, and also production of dissemination of conceptual and practical output towards strengthening the field of accountability in health. Our vision in COPASAH is communities are actively engaged in promoting accountability and transforming health system toward the realization of social justice with a mission to nurture, strengthen, and promote collective knowledge, skills, and capacity of community-oriented organizations and health activists, primarily from Asia, Africa, Latin America, and Europe, working in the field of accountability and social action in health, and also for the promotion of active engagement to make health system responsive, equitable, and people-oriented. Today in this webinar, we are so excited to look at issue of innovations and opportunities for social accountability in health as we are wrapping up this year and also moving into next year to prepare our COPASAH to engage in social accountability for health. So let me use this opportunity to quickly introduce the moderators and the panelists for this webinar, which is going to be a very short introduction. Then I will call in the MC to continue the conversation. Today we are going to listen from the PAI President and the Chief Executive Officer, Nebiha. We are going to hear from her, and we're also going to hear from Christina Wex, the Vice President of the Global Programs and Advocacy for PAI, based in Washington, D.C. And after hearing from them, we have our series of panelist speakers. These are our great practitioners and leaders across the entire globe. Denanje Kakade, from support for advocacy and training to health initiative SATI in India. He is the coordinator for the COPASAH South Asia and also the thematic COPASAH on private sector accountability. We're also going to hear from Dako Antik from Association for Emancipation of Solidarity and Equality of Women, ESE, North Macedonia, and also hosting the COPASAH Europe. Ariel Prisancho from Peru, the COPASAH South America, and also member of the COPASAH Steering Committee. We have also Mr. Salisu Musa, based in Nigeria, hosting the COPASAH West Africa, who is also the accountability lead in AHBN, where we are hosting the Global Secretariat. We're also going to listen from Buhumuza Abdul Karim from the Center for Health, Human Rights and Development, CHOD in Uganda, hosting the COPASAH Eastern and Southern Africa Hub. And also here with Benilda Bezin from Czech, Guatemala, who are also hosting the COPASAH in Mesoamerica. So these are our distinguished panelists today that we're going to listen to them and also sharing experience from the region and the thematic hubs and also different area of the social accountability for health. So without wasting a lot of time, let me return us back to Eve to introduce the next speaker. Thank you, Eve. Over to you.
Thanks, Aminu, for that wonderful overview of where we're going today. For opening remarks, I'd like to transition over to Nabiha Kazi Hutchins, who is our president and CEO of PAI. So Nabiha, when you're ready, please go ahead.
Thank you so much. Thank you, Aminu, and distinguished colleagues for having me here with you today and join you for this conversation. I want to share how proud we are of this collaboration and being associated with the work of COPASAH. It is an unprecedented network of those who are on the front lines advocating for equities in health, advocating for quality care, working in partnership with government, and at the same time ensuring that those who deserve the care that they have the right to access are able to get it consistently and in a quality and respectful manner. When I said also unprecedented, not only the heft and the depth of this coalition, but also the fact that it is led by leaders who are living in the communities where there are the greatest health disparities. So COPASAH is truly a network that is informed by communities most affected by disparities, and also informing policies and programs and change, quite frankly, from the perspective of their communities. And I think that is so important, especially in this day and time when we know that there is so much at stake, not only for the work, for example, for PAI around sexual and reproductive health, but also how we improve the outcomes for women, for youth, for other at-risk communities, and elevate communities at large. I'll be very brief today, but I did want to share with you just a few observations that I hope are useful for framing as you hear from colleagues today. PAI is also a civil society organization. We were founded 57 years ago, and we were founded with the primary purpose of holding our government in the United States accountable to make sure the funding, the policies, the intentions that are put out to support communities abroad in advancing sexual and reproductive health care were positive, were toward progress, we're inclusive, we're equitable. We still have a long ways to go, but we do speak truth to power to our government, share evidence and share calls to action, and hold our government accountable here in the United States. We do the same with major international institutions, with multilaterals, with global donors to inform and guide and elevate consistently what the needs are and why their words, why their investments, why their commitments matter, and why these critical health priorities should be at the center. The other component is the reality of the critical role that civil society plays in all of this. As I said, 57 years ago, we were founded as a CSO, as a nonprofit CSO, because we do believe that if we're carrying forward a voice, it should be a voice of the community. Our mission, quite simply, is to ensure universal access to sexual and reproductive health. We are part of a global movement that is not only committed to SRHR advances, but also to achieving health equity. And as part of any movement, as you all know, CSOs are at the heart of it. Civil society is at the heart of it. And we need many voices, many perspectives, and all of us working together to advance those. As I said often, and Aminu has heard me say this as well, is from my vantage point, civil society, we are the truth seekers, the truth speakers, and the protectors of progress. And that is clear day in, day out. Today, what I was excited to know as I looked at the agenda is we'll see not just one way that civil society and that COPASAH has been moving, but also how COPASAH and this network of advocates has worked together to advance policy, to advance evidence, to ensure that communities know their fundamental rights to healthcare. To the work on ensuring that there are tools that are created that can be shared across communities for social accountability, for other mechanisms of accountability that are led by communities. And all of that is incredible because these are the proof points and these are the critical elements that show the heft and depth of civil society advocates and ecosystems such as COPASAH to carry the work forward. There is power in one, but there's also power in this entire network. And related to that, you know, we all know the threats to our sector. We all know the unmet need. We're very well aware that the health equities that exist have only been exacerbated because of COVID and the erosion of health systems, because of displacement due to humanitarian crisis and so on and so forth. But again, CSOs are at the center, and I see three very critical opportunities as we look at a bigger picture of the reason for being and why networks like COPASAH, why civil society are so critical as we advance efforts. The first is there has to be an investment, yes, in civil society. I've made the case of that. But we also need to invest in the ecosystems that keep us all connected to each other. Networks like COPASAH. I will tell you that PAI, we have 120 funded partners. There are peer CSOs who work across 36 countries. And that connection, that unity fuels not only our advocacy, but also allows us to learn and share from each other, which ensures that we don't stop until the job is done, until we achieve the outcomes that people deserve to achieve. And we no longer have to fight this fight. So investment in individual organizations, but also investment in these ecosystems that bring communities together, bring voice together, and allow us to move in collective power. The second is that policies and programs and any change, quite frankly, and as evidenced today, as you will hear, require that CSOs be at the table, not only as observers and as one voice, but as true partners. And we're seeing time and time again how CSOs are now being welcomed in to join in partnership with government, with other institutions to inform the direction of programs, to inform the research agenda, to inform where investments should be made for the good of the people. And we need to reinforce that we are more than just voice, that we are also substantive thought partners who can help shape the trajectory of a country and shape the trajectory of positive outcomes for people. And last but not least, and this is not always exciting, and I mean it with so much love and respect to donors and those who are investing in our movement and in our work. We need to also invest in institutions, in keeping the lights on. We need to make sure that those who are doing the work, who are implementing the program, can sustain their staff, can develop the staff, can pay the light bill, can ensure that the rent is paid. Because if we are investing in a movement in the long term, we need to make sure that our civil society institutions and partners can weather those changes and are there and strong to pivot when there is a threat. So those are my three highlights. Again, I really want to thank all of you for having me here and allowing PAI to be part of this conversation. We're very proud to be in partnership with all of you, and we stand in solidarity and continue to fight the good fight arm in arm. Back over to you, Eve.
Thank you so much, Nabiha, for taking the time to join us today and give us this wonderful overview of how PAI supports COPASAH. Before we jump into the crux of this, the main panel, I do want to turn it back to Aminu just for a few minutes to give a very brief update on the Global Secretariat from COPASAH and what they've been working on to date. So Aminu, over to you just for a few.
So thank you very much, Nabiha, for this passionate opening remark. I'm so happy to hear, those words from you in advocating for strengthening institutions and strengthening health systems in the Global South. There's no better time than now to advocate that we have to support the Global South to strengthen institutions, particularly regional and country level organizations. We are moving into a post-COVID era where we need to strengthen health security, health financing, and social accountability. For us to achieve strengthening health security, accountability, empowering NGOs, young people to demand for accountability and social action, the institution, they must be strong. Otherwise, we cannot do it. So your passionate appeal to the donor community, the development partners, the leaders in the global north is vibrating everywhere. And I'm hoping that we're going to have a tweet after this event, or right there, somebody will pick up this your wordings to share. You are our friends of COPASAH, Nabiha, you are our champion, and also all the wonderful people in PAI. You are the friends of the COPASAH in the global north, and we appreciate that partnership, leadership, and coordination. The Global Secretariat sits in Abuja, Nigeria, where I'm greeting everybody. Nigeria is in the West Africa, the populous country in Africa, and also the populous Black nation. And at the same time, the hosting group in Abuja is the Africa Health Budget Network, which is a regional organization supporting Africa to promote social accountability and healthcare financing investment and mechanism. And within the COPASAH Secretariat, I'm the global co-convener. But of course, there's also a second co-convener based in India, Professor Abhijit, that is working with me to drive the agenda of COPASAH. Then within also the COPASAH, we have a steering committee which provide oversight to the Global Secretariat. And some of the members of the steering committee are already online listening to us, and some of them are also going to speak today, like Ariel, and also a lot of other wonderful people. Then we are also happy that PAI based in Washington are also hosting our grant from the Hewlett Foundation. So we are interfacing with PAI in implementing the grant. And we hope that as we move into next year and beyond, we will strengthen more partnership and more relationship so that the COPASAH can be one of the key players post-COVID recovery, and also equitable access to services, including vaccine and contraceptives and any other essential drugs. So I think with this brief talk, I want to say that the COPASAH is about the entire globe. We have regional hubs everywhere. Regional hub in the Europe, in Macedonia. We have the South Asia in India. We have in Mesoamerica, that is Latin America, in Guatemala and Peru. When you come to Africa, we have a regional hub in Nigeria covering the West Africa, and we have in Uganda covering Southern and Eastern Africa. When you look at all this distribution, this is the globe. The COPASAH is indeed a global South network and a leader in promoting social accountability. And we look forward to hear from our panelists and also from all the wonderful speakers today. So I will stop here and allow the conversation to run, and I will come back at a later time to speak. Thank you very much, and I wish the panelists all the best in the discussion. Over to you.
Thanks so much, Aminu, for keeping it nice and brief, but also thorough. Now I'd like us to move into the crux of the webinar, our very exciting panel. To moderate the panel, I am turning it over to Christina Weggs, who is PAI's Vice President of Global Programs and Advocacy, and she will kick us off. So over to you, Christina.
Thank you so much. I just want to say what a pleasure and a privilege it is to be here today to speak to leaders from across the COPASAH network. As Aminu said, this is a really critical and important moment, especially coming out of COVID. As he mentioned, this is a conversation today to reflect on progress and innovations and best practices across the COPASAH network over the past few years, especially as the network prepares for the next global symposium, which I know Aminu is planning for either in 2023 or 2024. I want to say I also feel very humbled because everybody who's going to be speaking today is a social accountability expert who's driving work in their own countries and regions, but also a global leader who's really advancing regional and global best practices in the field of social accountability in health. So with that said, I am going to start with our colleague Salisu from the African Health Budget Network. Salisu, you know, as we heard from Aminu, as we heard from Nabiha, civil society is critical to ensuring responsive, equitable, and inclusive health systems and healthcare delivery. And as you noted in before, Aminu, this is not about a tokenistic one-off engagement. This is about putting people, communities as rights holders in the center of really decision-making about health policy and health systems. The network of social accountability practitioners across COPASAH are driving social accountability at all levels, working at the front lines of healthcare delivery, advancing accountability at the district and national level with governments, even engaging with international NGOs and demanding accountability from multi-sectoral actors and multilateral actors like the WHO. I also know that you are collectively using a really diverse mix of accountability tools and practices, everything from budget monitoring to gender audits, social audits, or even at the global level, the WHO Watch. So I wonder from your perspective, if you could tell us about some of the exciting innovations and trends you've seen in government accountability over the past few years. And especially, we'd like to hear about what you've documented and submitted through the COPASAH West Africa Hub.
Okay, thank you, Christina. And thank you, everybody, for having me and the opportunity to share the work we do at AHBN with COPASAH West African Regional Hub. So to respond to this question, Christina, I would like to begin with the highlight of the regional trend tracked by AHBN. So I will begin with COVID-19 financings and accountability trend. So as we all know, during the COVID-19 pandemic, there is an inflow of financial and non-financial support to African countries from many partners, including World Bank, IMF, and many others. So at AHBN, we observe that African civil society organizations are not well informed about all these international resources and financings coming to Africa for the COVID-19 responses. So this actually compromises accountability, transparency, and prudent spending of resources. So in response to this accountability gap, AHBN tracked the World Bank credit and grant under the COVID-19 Strategic Preparedness and Emergency Response Program, which is a World Bank initiative. In 3 African countries, AHBN tracked this funding. These countries are Nigeria, Sierra Leone, and Liberia. So through the tracking of this COVID-19 intervention from World Bank, we found that Nigerian government received a credit of 400 million US dollars through the fast track COVID-19 facility, and also a grant of 14 million US dollars through the pandemic emergency financing facility, all championed by World Bank. Also, Sierra Leone received a grant of 7.5 million US dollars, while Liberia received a credit of 2.8 million SDR. That's the special drawing right of IMF, and also a grant of 3.5 million US dollars.
Salisu, I think that we've lost your sound.
Okay, hello?
Now we can hear you.
Okay. So these are information that the civil society needs to know so that they can track and also follow off the money to ensure judicial spending of the funds. So AHBN work with country level CSOs, young people, and media in the 3 countries, and established a country level accountability mechanisms, which we called COVID-19 Finances Accountability Working Group, which the members sensitized, engage state and non-state actors about implementation, transparency, and accountability of the World Bank COVID-19 grant and credit, using a spotlight which was developed by AHBN that highlighted detailed information about the program, the World Bank program, including the government agencies and officials responsible for the management of these funds and also the project's allocations. So this tool that was developed by AHBN comprised of every detailed information that civil society and media needs to advocate and also track this funding from the World Bank. Another trend that I will also speak about is the family planning commitment tracking. So over the period of 2021-2022, AHBN has been advocated and also made several calls for African countries to announce their FE 2030 planning commitments. And through that trend, AHBN actively supported the Ministry of Health in Nigeria to develop their FE 2030 commitments. And the government actually made 8 commitments, which among them, which we are highly tracking, is strengthening the integration of family planning into Nigeria's socio-economic development frameworks and plans. They also commit to increase family planning access and choices while scaling of evidence-based high-impact practices, and also improve financing for family planning by leveraging both existing and additional innovative domestic mechanisms, such as basic healthcare provision funds and National Health Act in Nigeria. And also the government commits to allocate 1% of its national and subnational health budget to family planning.
Wow.
So in terms of accountability, the Nigeria's commitment to recognize the importance of the accountability, which was actually promoted by AHBN and other partners, where the Ministry of Health identified the country RMNCH multi-stakeholder coordination platform, and also the National Reproductive Health Technical Working Group to be platforms for an avenue where for the government and other stakeholders to coordinate efforts and hold each other accountable. They also acknowledge using the motion tracker tool to monitor financial and non-financial commitments. So for the information, the motion tracker tool is implemented in Nigeria by AHBN. Other African countries also make commitment for family planning 2030, and AHBN are tracking such commitments. And some of them includes Kenya, which also made commitments to increase domestic financing for family planning commodities to cover 100% of the requirement. They make that to be achieved by 2026. So they made a lot of about 8 or 10 commitments, also Kenya. So AHBN is tracking this with the support and also with the collaboration of other civil society in the region, using evidences to advocate for the fulfillment of this commitment. AHBN also convene regional and global webinars with CSOs, media, and young people to discuss this commitment, to discuss how to track them, and what are the country level efforts by the civil society organizations. So this to share some of what we do at AHBN in terms of the social accountability, tracking government commitments, and resources, financial and non-financial resources that are available to government to respond to issues regarding healthcare. So thank you. I will stop here. I will be happy to come back for any question that you have. Thank you, and over.
Salisu, thank you so much. I think we could almost spend an hour just talking about some of the innovations that you've shared. I think it was really interesting how HBN and your partners really leaned in and demanded transparency about the funding that was being infused into different African governments during the time of COVID. And I also thought it was very interesting, the systematic approach to both catalyzing new and meaningful national commitments to funding family planning. That's very impressive to get a commitment from the government of a 1% of the budget going to family planning, but also the work that you are doing with others to make sure that those are not just commitments on paper, but the money actually flows down and you're tracking progress. Very interesting. So please, I just want to say, I'm sure others have questions about this exciting work. Please drop your questions into the chat or the question area, and my colleague Adam will be collecting them, and we'll make time for questions at the end. Thank you so much, Salisu. I want to turn now to Mahmouza. Mahmouza, I wanted to ask you about SRHR and specifically about some wins in human rights and also using litigation to unlock sexual and reproductive health and rights in Uganda. As we've been talking about, and I know is core to the sort of practice of COPASAH, is that community groups and CSOs are critical in ensuring that we hold governments and even private sector accountable for ensuring equitable access to healthcare. And that includes sexual and reproductive healthcare. One thing that's been exciting is over the past few years, COPASAH has been moving away from a top-down approach to thinking much more about SRHR accountability as a people-driven, sort of bottom-up accountability. Where community groups, civil society groups, even social movement actors are tracking emerging forms of rights violations in service delivery, where they are building, where CSOs are building communities' literacy about their rights and demand for their rights, and also creating spaces and platforms for people to negotiate directly with duty bearers for their rights. I'm wondering if you could tell me about some of the experience that your organization has and COPASAH has in Uganda, working alongside community groups to advance sexual and reproductive health and rights. Mahmouza, I think that you're muted.
Thank you very much, Christina.
There you go.
And also thanks to PI and the Global Secretariat for COPASAH for the continued support towards advancing work around SRHR in the region. I wanted to share a screenshot, but I see the host has disabled sharing the screenshot. But I'll go ahead and present on my side, if that's okay. So just to mention that the wins around SRHR and human rights litigations have not been just about one approach to work we've been able to use different strategies and innovations to be able to achieve some of the milestones around SRHR and human rights successes. One of them to mention that has been very critical has been around research and documentation, because we believe that research and documentation is very instrumental even in informing the influence of legal and policy decisions through the use of this documentation, but also we're able to come up with a number of documentation and knowledge products to inform the work that we've been doing with support from PI and other entities. So classically, at the beginning of COVID-19, we were able to work with our partners in the Eastern Southern region just to pick out, to understand the experiences they were shared, they were getting in terms of advancing SRHR and access to essential medicines. So we're able to do a kind of case studies on those emerging issues around governance and social accountability and health during the pandemic. And we got classical case studies from Kenya, South Africa, Tanzania, Uganda, and Zimbabwe, and some of these which informed part of our programming for this phase of work. But also we went ahead to do a couple of legal and policy analysis in terms of informing the work that we've been doing at the regional level in terms of advocacy for SRHR and access to medicines, even including access to vaccines, provided we've been in the pandemic. And very important, the shadow reporting to the UN Human Rights Council. We submitted a report on the rights to health and SRHR in the third cycle of the Universal Periodic Review, where we made critical recommendations, and some of these, we're happy to mention that they were taken up by the UN, and now we are looking at the country level implementation. But also another innovation and approach we've been using is about movement building. And movement building has been very instrumental for co-creation and joint regional advocacy for access for SRHR, but also access to essential medicines. And beyond that, we've been able to look at how do we leverage. We've been leveraging on other national, regional, and international networks beyond the COPASAH network, such as the People's Health Movement, which is in Kenya, in South Africa, but also been working with the coalition to stop maternal mortality in Uganda, the legal support networks around East Africa, the East African national networks of AIDS and health service organizations here, also based in Tanzania, and the coalition to prevent and safe abortion, which is based in Malawi, and the safe abortion coalition in Zimbabwe, among other networks, because we realized that if we were to achieve these successes, we have to work in movements that are existing to be able to leverage on those opportunities, but also the experiences within there. But also the element of being able to have concerted efforts on opposition monitoring and mitigation. Classic example around the East African community sexual reproductive and health rights bill, which has a lot of opposition from the region, religious leaders, from the cultural leaders, and other organizations that are against around this bill, which is quite progressive in terms of ensuring access to comprehensive sexuality education, but also comprehensive safe abortion care. But also very important, one of the other approaches has been around working with allies and champions among the law, justice, and order sector. The legislators, the policymakers, and academia, but also the media has been very instrumental in advancing our work around SRHR. Another approach we took over the years with this support has been on capacity enhancement, because one of the things we believe that we need more capacities, we need to keep orienting ourselves to understand the different dynamics around SRHR in the different countries we are working with, but also this has been a key approach to enabling partners and other stakeholders appreciate the concepts on governance and social accountability, but also the dynamics around SRHR, thus informing the strategic programming and implementation of the works we've been doing at the regional level and national levels. So through this, we're able to orient the partners around issues of governance and social accountability and health, human rights, and SRHR, and the role of community participation in addressing the existing gaps. Another very classical example around capacity enhancement has been the regional exchange sharing and learning that has been also instrumental in strategizing for more effective and innovative approaches to addressing SRHR barriers in the region. And we had very productive exchange learning visits in Kenya, in Malawi, in Nigeria, Senegal, and Zimbabwe, where we had a lot of lessons and learning for joint efforts around ensuring that we work together as movements, as countries to address the SRHR barriers. The other element, which was our last resort, was around strategic litigation. Most entities look at strategic litigation, and we've been seeing this as one of the approaches that we have utilized to hold the state accountable towards addressing the SRHR challenges. And a number of ongoing cases and successful judgments have happened within the region. For example, here in Uganda, we're having ongoing cases on termination of pregnancy, which are led by, for instance, CEHAD, and also Europe, one of our partners here in Uganda, but also other cases in Malawi, where we visited, and in Zimbabwe, that are all looking at how do we engage the policymakers, the communities, to address the barriers around access to SRHR services. Very important around strategic litigation also, we've been able to leverage on the successful judgment, such as the Malindi judgment in Kenya recently, but on which was specifically on allowing access to safe abortion care on specific grounds, but also the landmark judgment by CEHAD over the years around maternal health rights, and the positive judgment on comprehensive sexuality education, CSE in Uganda. These have been classical judgments that have been quite positive and encouraging, and giving the movement leverage on how we can strategize more to get more wins around SRHR litigations on the continent. Another thing has been about important to utilize the regional courts and other bodies such as the ECOWAS, the SADC, the East African community to advance realization of SRHR, because while we did these exchange learning visits in the different countries, we realized that they're even taking more initiative to go beyond the national courts, but to file these suits at the regional courts. And some of these have also been quite small wins at those levels, but also getting the champions and allies to work with. One other final element, of course, has been around resource mobilization, and this is mainly for research, capacity enhancement, and litigations to advance reproductive justice litigation in Africa. And we think this is the conversation we need to continue with if we are to get more wins around advancing SRHR in the region. So for now, I'll share that, and maybe perhaps as the conversation goes on, we'll be able to add on. Thank you very much.
Thank you so much. You've spoken about some really rich tactics that really would complement the community-based efforts that I was speaking about, we've talked about before. This point of doing in-depth research about rights violations and access to essential medicines, and using that as evidence for advocacy. And your work on strategic litigation is very, very interesting. I also hope we can hear a little bit more about the shadow reporting and work that you did at the Human Rights Council. But what you're talking about is kind of a linked system of accountability where, you know, we've heard before and we'll hear more later about sort of bottom-up accountability. And now you're talking about the importance of strategic litigation to make sure that there's enabling policy frameworks and even accountability for human rights at the highest level, such as with the UN Human Rights Council. Thank you so much. Please, just to let everyone know, we're going to make sure after this that we share all these tools, all these examples, because this is such a rich conversation. And drop any questions you have for Mahamuza into the chat. Thank you so much, Mahamuza. We have a few more questions for me, and then we really want to make sure that after we hear from each of the panelists, there's time for a discussion to go more in depth into all of the expertise and innovations we're hearing from everybody. So there's a next question I want to ask, and this is actually addressed to Darko, Ariel, and Binilda. And I'm going to ask each of you to answer this question. We'll maybe start with Darko. So, you know, in preparing for this webinar, Aminu flagged for me that, as always, one of the top priorities of the COPASAH network is to focus specifically on rights violations that are experienced by communities who face systemic discrimination and systemic exclusion. And this includes in many places indigenous communities, in many places people who are affected by conflict, displacement, or natural disasters, and also those who may be even discriminated against in majoritarian politics. So I'm wondering if we could start with Darko, and then also I'll turn to Ariel and Binilda and hear from each of you about some of the most important barriers that you're seeing to inclusive healthcare for marginalized communities. And then also tell us about some of the civil society-led actions to hold private and public actors accountable for delivering on health rights. So we'll start with you, Darko, to reflect on your experience from Macedonia and also in the European region.
Thank you very much, Christina. Greetings from Macedonia and Europe. Greetings from all members that are part of COPASAH Europe hub or network. COPASAH Europe is consisted of 20 organizations coming from different countries, mostly in the Southeast Europe. All those countries have different contexts, and but they share the same. All organizations share the same aim, or to improve the access of a vulnerable group of citizens, or in general citizens, to different kind of health services. Some of the organizations or the countries that are part of COPASAH Europe are members of EU. Some are not, so they share different experiences and implement different kind of standards. What is important for Europe, because is especially the history of development of the civil sector, which is different from Asia or Africa or Latin America, especially because most of the civil society organizations are not grassroots organizations, or they are organized or established in order to serve for some specific purpose, which is one of the biggest challenges in our work, especially when we are talking about citizens engagement and involving citizens, awareness raising and involving citizens in the decision making. That's why most of our activities were focused on in this area. Also, health as an area of work is limitedly covered by civil society organizations in the region. And also there are a small number of other networks that are existing in Europe and region, that are in the Southeast Europe region, that are covering health as or health rights specifically as an issue. What is the common for all these countries that are part of the COPASAH Europe is that all countries are facing with low level of accountability and transparency in the fiscal and also in the public health area. Also, privatization of the health sector is very dominant in this period. The influence of big pharma industries is also one of the biggest challenges that the countries in the region are facing. And all this complex situation make the public health sector, how can I say, damaged, or make the public health sector profit centered and highly corrupted. When I am speaking about the context, I'm speaking about the countries that are part of our network. Because of that, most of the citizens become, but in the same time, citizens are becoming very dependent or on a large number of services, especially after the pandemic with COVID, and also they are facing ability to reach all necessary services in the public health sector. Also, they're forced to pay high amounts of money in order to receive a proper treatment, and mostly they are using the private sector. In the same time, this makes the citizens poor because of the high level of allocations from their household's budget to cover their health needs. This is especially important for vulnerable groups because of their socioeconomic status, their ability to access information, and the level of awareness. What is important for the Southeast Europe region is that because of the whole political context, people are becoming very ignorant to the barriers that they are facing when they are accessing different kind of public services, not health specifically. The level of trust in the public system is very low, because there is no ask for improvement, governments are becoming more isolated or close to the citizens, for the citizens' needs. And in this regard, private private service providers are becoming like more powerful. And also because of the lack of trust, funds allocated for delivering of different kind of public services, especially health services, are decreasing, especially because because citizens do not want or do not pay taxes to the or avoid the payment of taxes to the budget. What is very important is that in Europe, the communication among civil society organizations and and also networks that are working in the area of health is on a low level. That's why through COPASAH we are trying to organize our efforts and also bring open space for joint discussions and joint actions among all actors in the field in the region. What we are doing as COPASAH Europe we are strengthening our members first, in order to empower citizens and to be able to participate in the public decision-making processes, and also actively seek changes based on the needs of the citizens, rather than personally identified needs. The other thing is we are also strengthen the collaboration among civil society organizations that are working in the field of fiscal transparency and corruption, and also civil societies that are working in the field of social and economic rights. Because they can complement their work and help each other in especially in reaching better public service delivery, and also better conditions for all the citizens. What is another aspect is that we are sharing experience, or we are trying to provide a field where our members can share their experience, and if they are working in a similar context and with similar groups, but they are applying different kind of methodologies. Then also we are working as a network, we are working with the public institutions in order to unify and to establish unified mechanisms for a continuous and also non-selective discussions among citizens. That's why I would like to emphasize that, for example, the Open Government Partnership initiative, where all countries in the region are part, we have used that opportunity for pushing the institutions in the area of social and economic rights to implement and introduce mechanisms for community or citizens consultations. Also, what is important is that we are trying to shift the trend, or the trend that is or the digital agenda among the countries in the region, from digitally focused to citizen-centered. And also we are trying as a group to develop and deliver joint submissions to the international human rights bodies, where we will address all the needs or all the findings that we have. In the
Hi,
past,
Darko. Darko, I'm sorry to cut you off, but to ensure that other speakers have a chance to go and still have time for questions, we're going to have to move on. But I really appreciate everything you shared, and we'll make sure that the appropriate resources for the rest of COPASA Europe's updates are shared out in the report.
Thank you, Don. I will finish here. If there are any questions, please feel free to ask.
Thank you so much, Darko. Really appreciate your time. Christina?
Yeah, I mean, I think that we can see we have so much to come together as a network and discuss. So I hope we can keep the drumbeat of these discussions up for the next year and then come together in the Global Symposium. Thank you so much for all that, Darko. And I'm hearing some really consistent themes here, including all the way up to international human rights bodies, but also this point of decreased trust in the public sector, decreased investment in the public sector, and the rising role of the private sector. And we'll be discussing that later. So thank you so much for that. I'm going to turn to Ariel. Ariel, perdón, no hablo español muy bien, pero voy a preguntarte en inglés. Could you please tell me from your perspective, especially in the South American region, what are some of the barriers to inclusive healthcare, especially for marginalized and excluded communities? And what are some of the actions that CSOs are leading to hold governments accountable?
Thank you, Christina, and good morning, good afternoon with everybody. Among the biggest obstacles, I would mention one main context of obstacle, which is the huge inequality gaps. Our countries at South America have improved the general economic situation by decades. However, inequalities are cruel and stark. And in general, Latin American societies don't raise the urgency or don't have the power to change this situation or address this injustice of the circumstances in which many people live. In terms of challenges indigenous communities find within health systems, I will place geographical access, which prevent them from accessing under-resourced health facilities. So the facilities they access are not all equipped or have all the medicines they need. Particularly, indigenous women who are poor, don't speak Spanish, suffer from unequal power relations, in which health providers could ignore their rights and entitlements. Moreover, information asymmetry and a poor accountability culture contribute to preserve the situation. Unfortunately, COVID-19 pandemic evidenced the lack of responsiveness of health systems which claim to be close to achieve universal health coverage. We could talk about that later, but it raised the concern on how universal health coverage could be understood and reached in the practice, not in the papers. What happened anyway with indigenous communities and historically excluded people was that there were long delays on arriving and being attended at hospitals. The dilemma of who gets the bed when you have an excessive, overwhelming demand was usually lost by those who have less power or agency. Lack of access to medicines and oxygen was also a problem. And private sector, as Darko has mentioned, show its worst face on this. And the system in general was in an overall functional collapse. Health workers exposed to people's desperation and anger and suffering themselves for fear and sorrow. But inclusive healthcare also comprises access to information. Language and messages should be tailored to the needs and ways of understanding of the targeted audience. We're talking about indigenous communities that have their own culture and their own language. However, national level provided along 2 years 2 patronizing messages, blaming the people for leaving their houses without understanding their need to work and getting income for their families. We have to bear in mind always that one size doesn't fit all, and this was one of the main mistakes of our system in Peru and other countries, and also the closing of the primary healthcare level. But coming again to communication, messages were not language or cultural adapted. The right to adequate information was also a non-respected right. Finally, and important, lack of opportunities and spaces for citizen participation on health policy design has worsened dramatically in recent years. It seems there's no interest on allocating resources for this from the governments. Which actions were taken? First, we began to regroup our members. We contacted rural health practitioners, indigenous women leaders who have provided important lessons on demanding accountability from governments and health teams. We facilitated their participation in a single national civil society dialogue for health policy recommendations promoted by a recently created civil society rights-based platform. So their voices could be present and they could give inputs to the recommendations. This effort will continue next year with a planned interchange between rural grassroots organizations of southern Peru implementing accountability on health. Along the pandemic, which is currently on its 5th wave in Peru and is beginning to raise in other countries, we have raised our voices to highlight access inequalities and specific barriers preventing indigenous women to access urgent vital care. But we also have raised concerns through webinars and social media on other excluded populations as people living with disabilities, and highlighted mental health challenges suffered by health personnel and communities themselves. Among diverse webinars and activities to share information of our experience, I would like to highlight the joint webinar with COPASAH Mesoamerica on vaccine access for indigenous communities, where we discussed and presented grassroots organizations' actions to inform and promote vaccine demand and access for indigenous populations. Inclusiveness of indigenous communities taking advantage of information, knowledge, and lessons shared by COPASAH is a challenge itself. We are addressing this through the construction of a web page in Spanish with appropriate materials on indigenous prioritized languages, but also analyzing other convenient tools that could ease the update sharing of information and diverse country collaboration. We will gather civil society leaders from Bolivia, Guatemala, and Peru to plan a specific strategy on how COPASAH South and Mesoamerica could serve better our indigenous communities' interests and needs of information to enrich their practice. Thank you.
Christina, you're on mute.
You're on mute.
I'm sorry. Thank you so much. That was so interesting. And I'm hoping during the questions, we could talk a little bit more about what you mean by universal healthcare in reality and practice, and the cracks between the aspiration and the reality that were revealed during the time of COVID. That was very interesting. Thank you so much. I'm going to turn to Benilda. Benilda, I wonder if you can share your experiences in terms of the obstacles that you're seeing to inclusive healthcare, and then also some of the innovations that are being led by civil society to demand accountability.
Bueno, muy buenos días y buenas tardes para todos los que nos están escuchando. Pues desde Guatemala, desde la voz de una mujer maya, etnia Tzutujil, pues les voy a compartir las acciones, los desafíos que tenemos como CEIS, que es un centro de estudios que realiza investigación, acción participativa en alianza con la red de defensores y defensoras comunitarias por el derecho a la salud, que es una organización de base comunitaria que tienen presencia desde las comunidades indígenas rurales, conformada por hombres y mujeres, líderes y lideresas que representan sus comunidades, que hacen una labor de monitoreo en los servicios de salud público, promoción del derecho a la salud, derechos humanos, acompañamiento a pacientes y la defensa de los derechos colectivos de las poblaciones indígenas y de las áreas rurales. Pues tenemos muchos retos y desafíos a nivel externo e interno dentro de la red y del CEIS. Voy a hacer mención de algunos que sí es muy preocupante y que eso ha venido desde hace muchos años, décadas, y que esto pues incrementó durante la pandemia. Uno de los retos es que el ministerio pues reproduce cada vez más inequidades y desigualdades en el país, afectando realmente a los más pobres de la región de Guatemala y la mayor parte de población indígena de las áreas rurales, donde no se tiene una cobertura universal para todos y todas, y que estos servicios no llegan hasta la población indígena. Otro punto importante es que pues ha tenido un impacto dentro de las distintos espacios del Ministerio de Salud, específicamente en el tema de la infraestructura que en vez de fortalecerse, pues se está debilitando cada vez más. Y durante la pandemia, pues ha habido como una exigencia de parte de la misma, de la misma situación vivida y que para el mismo personal, pues también hay mucha demanda, pero no se cuenta con insumos, no se cuenta con personal adecuado y mucho menos las infraestructuras. Y lo más preocupante aún es que ha habido una caída dramática de la atención a diferentes temas y voy a hacer mención de algunos, como maternidad, desnutrición, el tema de la vacunación, no solo de COVID, sino que vacunación de niños menores de 5 años, programas de salud reproductiva y personas que tienen enfermedades crónicas no transmisibles, que la concentración durante la pandemia fue específicamente en COVID y estos programas pues fueron aislados y mucha gente murió por no ser atendida. Y otro de los desafíos y retos es que no ha habido una estrategia de comunicación efectiva, pertinente y amplia de información sobre los distintos programas, pero específicamente sobre la pandemia, sobre el tema, sobre la enfermedad del COVID, el tema de la vacunación. Entonces eso generó una mala información, una información inadecuada y que esto pues también implicó otras situaciones. Y algunos retos internos que hemos tenido dentro de nuestra organización. Algunos defensores pues murieron durante la pandemia. Muchos de los defensores pues han tenido situaciones económicas complicadas porque debido a los protocolos implementados, pues la economía bajó, el cierre total del país y que la mayor parte de los defensores y defensoras son agricultores, son comerciantes y que eso debilitó su economía, motivo por el cual tuvieron que retirarse de la red y migrar a otros países para mejorar su calidad de vida. Pues algunas tenemos bastantes acciones implementadas, los retos enfrentados porque no estábamos preparados para esta situación de pandemia, pero uno de los temas emergentes que surgió fue que los defensores que están en las áreas rurales, que representan a sus bases comunitarias, pues nos solicitaron a nosotros como SEGS que pudiéramos desarrollar una formación sobre cómo abordar, ¿verdad?, la situación del COVID, porque era un tema nuevo para muchos y que la misma gente estaba exigiendo a la red de defensores que pudieran ellos pues compartir qué era el COVID, qué es la vacuna, las consecuencias, la efectividad de la vacuna. Entonces nosotros como SEGS tuvimos que brindarles una asesoría técnica, informativa a la red para que la red pues pudiera informar a la población, sobre todo en los idiomas locales. También como SEGS tuvimos que, como les comentaba, no estábamos preparados, pero tuvimos que hacer gestiones ante diferentes donantes, ¿verdad? Para que pudiéramos dotar a la mayor parte de defensores posibles con teléfonos móviles, que como era el único medio que teníamos con que podíamos contar para poder informar a ellos, entonces tuvimos que gestionar recursos para la compra. Pero ya contando con los teléfonos, pues se tuvo que ver cómo enviarles a ellos hacia las comunidades, pero sobre todo poder brindar una asesoría técnica a ellos sobre la utilización de las distintas herramientas sociales, porque en la mayor parte de las áreas rurales la señal de internet es muy baja y no solo eso, sino que muchos defensores no habían tenido un teléfono smartphone, entonces fue un reto grande para nosotros para poder a larga distancia indicarles a los defensores cómo usar un teléfono móvil y que eso fue una herramienta clave porque por medio de esos teléfonos pues se generaron evidencias de lo que estaba pasando en las comunidades, de las distintas situaciones. Y a través de eso también, como les comentaba, de que los defensores realizan acompañamiento a pacientes en los diferentes niveles de atención, en los hospitales más. Entonces tuvimos que dotar a los defensores de un equipo para poder ingresar hacia los hospitales, brindando acompañamiento a los pacientes que requerían. También, pues, ya habíamos venido trabajando sobre un curso, pero por la pandemia lo tuvimos que agilizar y se implementó una escuela ciudadana por el derecho a la salud, que la mayor herramienta utilizada ahí fue el WhatsApp, que por medio del WhatsApp nosotros compartíamos videos de 10 a 15 minutos sobre distintos temas. Para empezar, el derecho a la salud, derechos humanos, el marco legal que ampara a nivel nacional, internacional, sobre los derechos humanos, el ejercicio de la participación ciudadana, porque para muchos el tener un servicio en una comunidad es un favor que el Estado nos hace. No reconocen las comunidades que eso es un derecho y que ellos pueden exigir ese derecho. Entonces nosotros aprovechamos a través de esta escuela ciudadana que la mayor parte de la población conociera sus derechos, que ellos pueden demandar, pueden exigir, pero también pueden ser parte de la construcción de propuestas para mejorar sus condiciones de vida, especialmente el de salud. Y dentro de los distintos acompañamientos que la red dio, que siempre ha dado y que fue más durante la pandemia, pues los mismos pacientes, los mismos usuarios demandaban a que los defensores los acompañaran y también se les negaba la información a inscribir a sus hijos recién nacidos, entonces se tuvo que acompañar y fueron diversas las acciones que la red ha realizado. También se acompañó a familias que tienen hijos con un alto grado de desnutrición, que igual se descuidó esa parte. Entonces, esto ha generado la confianza, no solo de las bases comunitarias hacia la red, sino que también ha generado una confianza entre el servicio de salud, la comunidad y los intermediarios, son los defensores que por cualquier situación que pasa en la comunidad o que pasa en el servicio, acuden hacia los defensores para que los defensores sean los intermediarios para irme buscando solución a las diferentes situaciones que pasan en las distintas comunidades y regiones de Guatemala. Muchas gracias.
Muchísimas gracias, Benilda. It was very interesting. I heard you bring some of the same themes that Ariel and others have mentioned about people not even sort of believing and understanding their rights to hold the system accountable and demand equitable services. I also thought it was very interesting how you pivoted very quickly to using cell phones and even WhatsApp to do a citizen school to kind of build that literacy and demand for rights, but also how it got down to even needing advocates to accompany people to healthcare to negotiate the point of service delivery for equitable care. Thank you so much. We are running out of time. We have one more speaker and then we might have time for some questions, but just to assure you, if we don't have time for big question and answer, this is just the beginning of a conversation. I'm going to turn to our last speaker, Dhananjay. You know, one of the things that's been coming up as a theme throughout this conversation is the increasing prominence of private sector healthcare providers. And I'd love to hear about some of your work, but also the work you're seeing of other COPASAH members to identify and document the rights violations that are taking place in the context of private sector healthcare, and then also some of the actions that citizens are taking.
Yeah, thank you so much, Christina. I just want to confirm you're able to hear me.
We can hear you great.
Yeah, and unfortunately, I have to switch off my video because the internet here is a bit poor.
That's fine. We're just glad you're with us.
Yeah, so I'm representing Hub on Accountability and Regulation of Private Health Sector and South Asia Hub in Sathi. And COVID has regulation of the private health sector and unaccountable behavior of the corporate health sector are deeply entrenched issue, very protracted issues. But the depth and magnitude of accountability crisis in the private and corporate health sector has been felt far more acutely during the time of pandemic, especially in South Asia and especially in a country like India. So one thing that we were trying to do during the pandemic and even after the pandemic is to center on patients and how accountability crisis has been felt by people who went to private hospitals and corporate hospitals. So this important study that we want to publish very soon, and that will be a study on analyzing implementation of COVID-specific rate regulation that's been issued by our state government. I'm from a particular state in India, Maharashtra, which is central state. And we have witnessed largest number of deaths during COVID. And we have interviewed more than 100 respondents, and there are 11 in-depth interviews of doctors just to understand the pattern of accountability crisis or accountability deficit, to put it mildly, during the pandemic. And this will be sort of a very interesting report to see how private sector unaccountable, non-transparent behavior actually impacts patients. In many ways, even individual patients, if they are pursuing accountability from the private sector, I do consider them also as accountability practitioner, even if they are not related with COPASAH. So that's an important sort of a point to note down. Besides that, we have also been instrumental in mapping down what has happened in other countries and to understand are there any specific actions laid by civil society organizations or different groups to tackle the onslaught of this commercialization and privatization of health services? So on 20th May 2021, we had this global webinar on tackling commercialization and corporatization of healthcare, highlighting people's experience in the time of COVID, moving towards the social regulation and universal access to healthcare. So this webinar was attended by more than 100 people, and there were representatives from Africa, Europe, UK, almost all parts of the world. And this gave us a glimpse that the drivers of sort of very pathological forms of commercialization, corporatization, and privatization are rooted in global economy. And many times you require constellation of accountability actors at a much larger level to tackle it at a global level. At a national level, what we can do is to identify people, institutes, and different approaches to actually challenge this. So this webinar and subsequent webinar that we had also in September 2022 this year is the post-pandemic agenda for a private and corporate health sector. This was specifically focused on India, but we made it a deliberate agenda to make it multi-stakeholder, where we have involved not just people who are working in the health sector, but journalists, activists who are working on freedom of information, activists who are using legal approaches, and sort of a collectivization of different individuals and institutions who are concerned about the accountability crisis of the private health sector. So besides that, key policy lessons from different countries, that is what we are also trying to map, identify, and document so that it becomes a useful knowledge for all accountability practitioners in different parts of the world. There's a bewildering variety of how unaccountability looks like. So there's no uniform pattern. I mean, if I have to talk about only one state which I belong to, the unaccountability that we have witnessed in different cities was slightly, it was so diverse and different. And in a way to develop sort of a common framework of how it needs to be tackled, we require a sustained effort of actually contacting different people who have been using different tactics. We also need sort of a collection of different tactics and tools to address non-transparency and irrational care in the private health sector. A network like COPASAH is indeed useful in terms of really getting a sense of what is the political economy of regulation of private sector in different parts of the world. And are there some common lessons, and are there peculiarities that we need to keep in mind when we are actually trying to develop new advocacy and action strategies? I will also like to emphasize on one specific factor as far as accountability of private and commercial health sector is concerned. Unlike public health sector, accountability framework for the private health sector is not well defined, and that's a gap, especially in South Asian countries where the history of public health system is not very strong. We also do not have institutional capacity to have a rigorous regulatory framework in place for the private health sector, unlike what you have in Europe, or because we don't have that kind of institutional history. Of course, there's also an element of political will to implement a regulatory framework. And the last point that I want to make is also a question of narrative. Despite public health sector making a case for itself during pandemic, and all of us should unapologetically also say that future is public, but yet all the policymakers and all the management consultancy firms in the world are actually looking in the opposite direction. So the prescriptions for further privatization and commercialization of health sector are not going to stop in near future. The question is, how do we develop a counter discourse? How do we really document community and individual patient experiences in a form that becomes a compelling case for people who are really pushing for non-evidenced sort of a push for privatization and commercialization of health services? That's going to be a huge challenge, but I believe with a collective like COPASAH, even that will be possible. So I'll stop here. Thank you so much.
Thank you. That's beautifully put. And I think such a challenge for us all collectively. I was really struck when you talked about how it's not stopping but growing, the movement towards commercialization and privatization of healthcare, and that you're seeing increasingly, as you put it, pathological forms of this healthcare. And also, in your context at least, that's coupled with the fact that there is a poor regulatory environment, and also that collectively we're really missing a framework for accountability for the public sector. But that this is a trend, it's moving, and that this is really a call to action for all of us is what I'm hearing. So thank you so much. So we have just about 10 minutes left. I'm going to hand it over to Eve to start the questions. I know Adam has been keeping track of some questions. I don't know if you have some questions for me. I'll open them up. Eve, do you, if you have access, I can't open up the questions. Could you maybe start and ask the questions?
Sure. We only received one so far, so I encourage, we could probably take about one question. One was submitted and it was already answered by Salisu. So unless there's more, I can repeat the question, and if Salisu wants to just say a couple of words to narrate his response, that would be fine. We had a question: what's the involvement of the young people in the processes of accountability with AHBN? Salisu, if you're still with us, do you want to just summarize your response in lieu of there not being other questions?
Okay, thank you, Eve. Yeah, just as I drop in the chat box, youth constituency is one of the key partners or constituency the AHBN is working with, and we strive to strengthen their capacity. We We are currently hosting the Nigeria Meaningful Adolescent and Youth Engagement Working Group, which is a diverse group with many members across Nigeria from different backgrounds, working to raise the voice for youth. And we are strengthening their capacity. We provide them with platforms to participate in government-led meetings, partners meeting to also voice out the youth voice at such kind of meetings. And currently we have about 4 members of the MAI group as members of the Nigeria Multi-Stakeholders Partnership Coordination Platform, which is one of the highest platform in Nigeria that's discuss RMNCH that comprises the government agencies and also private actors, non-state actors. So they all, as the youth sit at that table to discuss and also share their own experience and opinions on matters that are related to youth health. So that's what I can summarize from this. Thank you.
Thank you so much, Salisu, for just adding your narrative. So we have about 2 minutes left. Christina, I want to flip it to you if you have anything to close the panel with. Otherwise, I'm happy to turn it to Aminu to close us out. Christina, anything else from you?
I mean, just to say, I mean, I wish we had more time for questions. I think we could spend a long time talking. I mean, what really struck me today was how we're seeing the importance of this very diverse set of accountability practices, from direct accompaniment of patients to negotiate for care, to building rights literacy, to building platforms for citizen groups to navigate with systems, but also all the way up to strategic litigation, all the way up to building regulatory frameworks, all the way up to, you know, national, regional, and global human rights councils. And so what I'm hearing is this important sense of this linked system of accountability. But also I've heard a lot about how you have all innovated in the face of a huge shock, which is COVID. And I just thought it was very interesting. I just want to sort of leave with what Ariel said, that we have kind of a story and a myth about progress we're making in universal access to healthcare, but COVID really revealed big cracks in that system and how far we have to go. And this point, please add, Ariel.
Yeah, just very quick. Universal health coverage is effective coverage of quality healthcare for everybody. In some Latin American countries, we have called universal health coverage to universal health insurance. That means having a system or so-called system that is going to protect you economically if you arrive to the hospital. But universal health insurance could be just universal health registry for indigenous populations. It's like if I say somebody in Peru, okay, you have free healthcare in Miami. Your problem is how you arrive to Miami. And that's not universal health coverage at all. And also the dimension of information for participation and the spaces for participation are part of the health rights as well.
Fantastic. Listen, I'm going to hand it over to Aminu just to say, I hope that this, one thing that Aminu and Salisu and others have asked PAI to do is to stand alongside you and help create more spaces and platforms for this incredible learning as kind of a drumbeat up to the next global symposium. And just to say what a privilege it is for us to be invited in to be part of this conversation, I'm going to hand it back to Aminu to wrap us up. Maybe you can tell us a little bit about next steps, Aminu. I think you're on mute. Salisu, if we've lost Aminu, do you want to come in from the African Health Budget Network?
Hello.
Hello, hi Aminu, there you are. Can you let us know what comes next or any parting words for us?
Yeah, okay. I lost connection, but I hope you can hear me now.
We can hear you now.
Okay. So I think it has been a very wonderful engagement and a great conversation. that we need to continue the conversation. I'm sure Christina and everybody will agree that we need to continue this conversation to promote social accountability in the health sector and a very global movement via the COPASAH. So we need to come back in January to start planning and explore the possibility of convening maybe on quarterly basis the global webinar. It doesn't have to be a global webinar. It could be a regional webinar or a country webinar to pick a particular topic. But I think we need to come back to plan so that more discussion and more topics can also be done. So it's important to do that. And also as we move into next year, the social accountability become more relevant as we move into the post-COVID era, the equitable recovery in terms of economy, health, and health security, and also social accountability. So with this, I would like to thank everybody that joined this webinar, including all the panelists from the 6th region. It has been a wonderful seminar, hearing from West Africa on health financing, hearing from East Africa on litigation, hearing from the Europe about vulnerable people and women, going to Latin America, looking at marginalized population, and also from India, South Asia, learning about issue of human rights, patient care, and also patient-centric social accountability. These are great ideas and innovation that we need to continue. Okay. We also thank PAI team, Adam, Eve, Christina, Nabiha. They have done so well as our co-partner and our host for the grant. We continue to engage you and also to build more partnership and also more synergy. We hope to come back to you to also discuss the global symposium, which is going to be a rider to this global webinar. I'm sure Christina will have that discussion to find a way of convening a global symposium either late next year or early 2024, so that more people will be invited to a conversation and also promote the charter on social accountability. So with this, Eve, I say thank you very much for the hosting and also for the webinar. And I wish everybody, a successful post-webinar and also Happy New Year.
Happy New Year.
Okay, thank you everyone for joining today. We're going to close the webinar. Thanks so much, Aminu, Christina, and all of our panelists. Have a good evening, afternoon, morning. Bye.
Bye-bye. Thank you. Thank you very much indeed.
Bye. Thank you.
Thank you, everyone. Bye-bye.
Thank you, everyone. Bye.
Muchas
Thank you.
gracias. Feliz día.
Thank you and bye-bye.
Thank you, everyone. Bye.